Welcome to PGOG-Pathways to Growth in Obstetrics and Gynecology for postgraduates and consultants. Today's topic is labor analgesia. Now, labor pain is complex in nature and it is subjective. It is an unique experience for each person. Memory of this pain during delivery is surprisingly short-lived. Now, it includes visceral pain as well as somatic pain. Visceral is arising from viscera. Visceral pain is usually deep-rooted, dull aching, and it is difficult to point out the area. Whereas on the other hand, somatic pain is from skin, muscle, bones, joints. It is sharp and it can be localized. So labor pain has both the components, visceral as well as somatic. If we see the viscera, uterus and cervix, as compared to the body of the uterus, cervix has a central role in production of labor pain. Visceral pain is because of the dilatation of the cervix and lower uterine segment, which occurs in first stage of labor, early first stage, and early second stage of labor. It leads to the stimulation of afferent nerve fibers from T10 to L1, and it responds to opioids. So it is from T10 to L1, visceral pain, and afferent fibers are carrying this. It is because of the cervical dilatation and stretching of the lower uterine segment which takes place during labor. Somatic pain is because of the distension, stretching, ischemia, and injury to the cervix, vagina, pelvic diaphragm, and perineum, mainly the passage of labor. It takes place mainly in the late first stage. Excuse me. It takes place in late first stage and late second stage of labor. And here, what we see are the S2 to S4 are the main nerve fibers which are involved, and from L1 to L2. So L1 and L2 and S2 to S4 mainly are responsible for creation of this somatic pain during labor. Somatic pain responds to local anesthetic drug. So if we see any epidural analgesia, which is the most effective and most commonly used all over the world for labor analgesia, here whenever we are using to a drug, usually it is a combination of these two drugs. It has local anesthetics along with opioid. The reason is local anesthetics will take care of the somatic pain, whereas opioid will take care of the visceral pain which is being produced during labor. Why labor analgesia? WHO says that we need to have a respectful maternity care with dignity, privacy, and support during labor. So labor analgesia forms important component to maintain dignity of a laboring woman. Techniques are, we can divide as pharmaceutical, non-pharmaceutical. In pharmaceutical, we can divide it further as neuraxial and non-neuraxial. Neuraxial, the meaning is near the spinal cord. So near the spinal cord is neuraxial, where we have again four types: epidural analgesia, combined epidural spinal, combined spinal epidural, dural puncture epidural, and continuous spinal analgesia. I will repeat once again. Most commonly used and gold standard till date, which is being considered, is still epidural analgesia. But because it has certain shortcomings, other techniques are also being used to overcome these shortcomings. And one of the other one of the that technique is this combined spinal epidural. Second is dural puncture epidural. And third is continuous spinal analgesia. So we need to remember all these four types because these are being used more and more frequently all over the world. So this is a pharmaceutical neuraxial type of the labor analgesia. Non-neuraxial, that is where we are not giving any drug near the spinal cord, will be opioids, NSAIDs, acetaminophen. These are given as injectables. and nitrous oxide, which is given as as an inhalation form. Equally important are non-pharmaceutical methods. Transcutaneous electric nerve stimulation is TENS, acupressure, aromatherapy, hydrotherapy, massage, breathing exercises, music therapy, and doula support. Let us start with Nauraxial analgesia. What is common for all these four? Epidural analgesia, combined spinal epidural, dural puncture epidural analgesia, and continuous spinal analgesia. What is common for all these four is each one of these can be converted for emergency cesarean section if there is a need arises when the patient is being given a trial for a vaginal delivery. Epidural analgesia can even provide post-cesarean section pain relief also. Now, all these types have no effect, fortunately, on uterine contractions. Uterine contractions are absolutely spontaneous in nature, or these are not uh, under the cover of these nerves which we are blocking for the pain relief, and that is the reason involuntary uterine contractions are not getting affected by any of these type of analgesia. All these are likely to produce transient maternal hypotension because of the vasodilatation and transient fetal bradycardia. These are associated with prolonged second stage with increased need for operative vaginal delivery. All these. There is a reduction in maternal mobility whenever we are using this. In obese patient, there can be difficulty in placement of all these types of neuraxial analgesia. And all these are likely to produce complication, that is post-ductal puncture, post-dural puncture headache. PDPH, post-dural puncture headache. Commonly used drugs are, as I have already said, it is a combination of local anesthetics which takes care of somatic pain, and visceral pain we have opioid. One example is ropivacaine, that is a local anesthetic, with levobupivacaine, which is an opioid. On this anatomy, as obstetrician also, we should be aware of what our anesthetists are mainly trying to do. And whenever you say, I want patient to be given epidural, or I want patient to be given combined spinal epidural, we should need to have the clarity about what is the anatomy and what exactly is happening to our patient. So that is why this diagram is important. What here we can see is this is ligamentum flavum. After that, the nerve fibers are being protected by meninges, and there are three layers of meninges. Outermost is a dura mater, which is tough. Then is a arachnoid matter, which is delicate, and pie matter, which is adherent to the nerves. And these are the spinal nerves at the center. So what is epidural space? It is nothing but the space between this ligament flavum and dura mater. Spinal space, whenever spinal anesthesia is being given, it is in between this dura mater and arachnoid mater. That is why it is also called as subarachnoid space, which contains CSF. So there has to be a clarity that dura is getting punctured, then it is spinal. And when the needle stops short of the dura mater, then it is epidural space. Epidural analgesia is gold standard. It is also recommended by WHO. Certain disadvantages are it leads to prolonged second stage because of a slower descent of the presenting part in second stage of labor. There is a delayed, inadequate, or absent sacral block. So towards the end of the second stage of labor, patient might feel pain in spite of being given the epidural analgesia. Sometimes it can lead to unilateral bleeding. There is a slow onset of action, and high total drug consumption is there associated with need of a drug which is required to have the adequate labor analgesia, the need is greater. So that total dose which is being used is greater. Now, when should it be started? Initially, it was thought that should it be started before 4 centimeters, and there were concerns that if it is started in early labor, whether it can itself lead to labor dysfunction or dystocia. Then another opinion was whether it should be started at 4 or at 6 centimeters. But the current opinion is it should be can be started any time during labor on patient's request. So most of the guidelines are now recommending that epidural analgesia can be given to the patient provided whenever patient is requesting for the reduction of the labor pain. What is done in epidural analgesia, how it acts, mechanism of action is catheter is placed in the epidural space. So here as we can see, there is a interspinous ligament through which the catheter will be passing. Then there is this ligament flavum, and once it crosses the ligament flavor, the red space is epidural space, which is short of the dura mater. So the tip of the catheter is in this epidural space, and then the medication is injected. This medication diffuses along dura mater, and then it goes and blocks the nerve fibers. Nerve roots carrying the pain signal to the brain are blocked. Now it takes the action takes around 20 to 30 minutes. Pain relief occurs after that. With epidural, there is a reduction in the maternal mobility. Position change is possible, but usually walking during labor with epidural analgesia is not recommended, because there is some risk of there is a sensory block as well as there can be motor block also, and the extent of the motor block is sometimes unpredictable. There is a risk of fall for the patient if we encourage walking, and that is why walking is usually not recommended. Now the drug can be given as in the continuous administration, or it can be given as intermittent administration, programmed intermittent administration by using infusion pump, or even manually it can be given intermittently as per the patient's need. Now, what is done in this combined spinal epidural is spinal needle passes through epidural catheter itself, and it pierces the dura mater, and the small amount of drug is injected in the spinal space, and then this needle is removed. After that, the catheter tip is in the epidural space, and intermittent epidural administration is continued. So understand here that through this catheter only we are passing a spinal needle, and a single shot is given in the spinal space. Needle is removed, and then remaining procedure is same as for epidural intermittent administration. What is the advantage? There will be immediate pain relief because we are injecting the drug directly in the spinal space, and that leads to more maternal satisfaction. If the studies are done comparing randomized control trials, comparing this combined spinal epidural with epidural, and the maternal satisfaction was greater because of this immediate pain relief. Less total dose of the drug is used. If higher drug is used, then it can lead to more maternal hypotension, headache, nausea, or vomiting. Dural puncture epidural. What is done in dural puncture is catheter is placed in epidural space, and needle is passed and needle pierces the dura mater. So dural puncture is done. Then needle is removed. Drug is not administered in spinal space. Drug is injected through epidural catheter in epidural space only, with the possibility that drug diffusion can take place easily through this dural puncture, so that the efficacy will be greater as compared to the epidural analgesia. Better drug diffusion will be there. But there is increased PDPH risk, that is post dural puncture headache, because we are deliberately puncturing the dura. the risk of post-dural puncture headache is greater. There are less maternal and fetal severe side effects with this dural puncture epidural as compared to epidural because the total drug which is being used is amount is less. Next is this continuous spinal analgesia. What is done there? That is a fourth type. What is done here is intrathecal catheter is used, and the catheter will be crossing the dura mater and the drug will be directly getting injected into the uh, spinal space. Action is quick, rapid onset, symmetrical action will be there. Low drug dose of the drug is needed. Rapid onset already we have seen, and there is a less prolongation of second stage of labor is the another advantage. But there is increased PDPH and transient neurological deficits are also recorded, and it is used. These are this is the technique which is used mainly with inadvertent dural puncture. That means we are trying to go for epidural, but inadvertently dura is getting punctured. Then you change the technique from epidural to continuous spinal analgesia. This is emerging method which is being used by choice also by some centers. So choice of neuraxial analgesia, the epidural is most common. Other options are there to overcome the disadvantages of epidural, but the choice ultimately depends on anesthetist experience, clinical situation, and available facilities. What is the effect of this neuraxial labor analgesia on labor? It might lead to prolonged latent phase. Prolonged latent phase by definition is greater than 20 hours in nullipara and greater than 14 hours in multipara. Then active phase is starting at 6 centimeters instead of 4 centimeters with the use of this neuraxial labor analgesia. Rate of cervical dilatation mainly slows down from 4 to 6 centimeters, leading to flattening of cervicograph. It might lead to incomplete rotation in occipito-posterior position because of reduction in abdominal pressure and relaxed pelvic floor with the neuraxial analgesia. Now, presently, labor care guide is using Jank curve, which was introduced in 2002, instead of Friedman curve, which was introduced in 1955, where the active phase is considered to be starting at 6 centimeters and not at 4 centimeters. And the main reason was mainly in developed countries, almost 75% of the normal deliveries are being um, uh, taking place with the use of some or the other form of this neuraxial labor analgesia, with epidural analgesia being the most common. And that is the main reason why this labor curve has shifted from Friedman to Zank curve. So as we can see here, there is a flattening of the curve. This is the Friedman, where there was after 4 centimeters, there was a phase of acceleration, 4 to 6 centimeters, and then there was a phase of maximum slope and phase of deceleration. Instead of that, what Zhang has seen or created a curve in 2002 based on multiple labors which were observed is acceleration. True acceleration is taking place not at 4 but at 6. From 4 to 6, there is a slower rate of dilatation or there is a flattening of the curve, and this change is mainly one of the reason is greater use of neuraxial labor analgesia, epidural analgesia. Other effects are this epidural analgesia might lead to pseudo-sinusoidal pattern on CTG. Late decelerations can occur transiently whenever there is a maternal hypotension. Once you correct the hypotension with change in maternal position and giving IV fluids, then there will be this late decelerations usually disappear. Prolonged decelerations, where the deceleration is lasting for greater than 2 minutes but less than 10 minutes, are also sometimes observed in 1% of the patients where epidural analgesia is being used. All these are usually transient changes which are taken care of by proper um, care about the maternal parameters. And this epidural analgesia can lead to post, or all these type of neuraxial analgesias are associated with increased incidence of postpartum urinary retention. That also we need to remember. What are the absolute contraindications of neuraxial analgesia? Refractory hypotension, maternal hypotension which is not responding to IV fluids, thrombocytopenia where the platelet count is especially less than 70,000, maternal coagulopathy, prophylactic low molecular weight heparin which is being given within 12 hours, untreated bacteremia, skin infection at the site of the needle puncture, and increased intracranial pressure. It is very important. This list should be in our labor room or labor ward so that anytime we are considering if this patient is for epidural analgesia or any type of neuraxial analgesia, we need to check that any of these are not there. Platelet count is mandatory before taking the decision. Now, various obstetric conditions and this neuraxial labor analgesia, multifetal pregnancy, it can be used safely. On the other hand, it helps in internal podalic version or emergency cesarean section if required for the second baby. For trial of labor after cesarean, it can be used, but the word of caution is it can mask the pain of the scar rupture. And whenever there is an increased need for the labor analgesia dose, greater with a greater frequency and increasing dose is required, we need to be careful to rule out scar rupture. In heart disease cases, it helps as it reduces pain-induced tachycardia. This neuraxial analgesia helps in majority of the cases of heart disease, except in two situations: pulmonary hypertension and aortic stenosis, where as this analgesia might lead to peripheral vascular dilatation and possible hypotension that can lead to the worsening of the condition, and that is why in these two conditions, this usually epidural analgesia or neuraxial analgesia is avoided: pulmonary hypertension and atrial stenosis. In hypertensive diseases complicated in pregnancy, it can be used, but not to control the hypertension, only for a labor analgesia. In severe preeclampsia also it can be used, but we have to be cautious that these are the cases where sudden hypotension is more commonly observed after giving neuraxial labor analgesia, and we need to be monitoring the patient and correcting it promptly. Maternal asthma, epidural analgesia is ideal. In any antepartum hemorrhage, this epidural neuraxial labor analgesia is to be avoided because already there is a pre-existing hypovolemia which can worsen the which can worsen the patient's condition with addition of the procedure-induced hypotension. Complications of neuraxial analgesia, post-dural puncture headache is one. In epidural analgesia, how it leads to post-dural puncture, because here we are not intending to puncture the dura, but still there can be accidental dural puncture which can lead to this PDPH. It can occur with combined spinal epidural, dural puncture epidural, and continuous spinal analgesia. It occurs whenever it is more commonly seen whenever there are multiple punctures are required. It is because of the CSF leak and traction on the brain. It is a postural headache. Treatment is with caffeine, or the new treatment which has been introduced is epidural blood patch. I have not seen this, but when I went through the literature and found this as a modality of treatment, it seems to be exciting one, where patient's own blood, autologous blood, is taken 10 to 20 ml is drawn, and then it is injected in the epidural space, which takes care of this headache. It leads to immediate relief. It has been given in Williams. Epidural hematoma can occur, especially if platelet count is low, and that is why the cutoff which is considered is it should be greater than 70,000 per microliter. Maternal hypotension can occur. It is usually transient, and preloading usually prevents it. There can be epidural analgesia associated maternal fever, which is not infective in origin. It is thought to be inflammatory in origin. Fetal heart rate abnormalities are most of the time self-limiting. They do respond to IV bolus, maternal repositioning, and tocolytic use, such as there can be appearance of prolonged or late decelerations, or there can be pseudo-sinusoidal pattern. If the catheter, epidural catheter is placed in wrong place, then there can be life-threatening complications, such as if it is in a vessel, intravenous, or it is in a subdural, or by mistake it is subarachnoid. And then the drug which is being pushed is usually very large in amount as compared to the drug which is used for spinal analgesia. And this large dose will lead to severe side effects. Severe CNS toxicity will be there. Patient can have convulsions, patient can become unconscious, and there are severe CVS toxicity also. Various types of arrhythmias also can occur. Prevention is by using a test dose of the drug with epinephrine. Small dose is given and response is seen, so that it rules out the possibility of this catheter tip being present in a vessel or subdural space or subarachnoid space. High spinal blockade can occur sometimes because of the drug which is given, which goes in the spinal space, leading to respiratory arrest also sometimes. Treatment is intralipids, which are detaching the drug from the nerve fibers. Sometimes this epidural analgesia will lead to inadequate effect. It is seen in around 10% of the cases. Lumbar arachidonitis, that is infection, that is a rare complication. Pruritus can be there whenever opioids are used for this epidural analgesia. So, in what is most important is we need in-house anesthetist in labor room. It is not that anesthetist will come and initiate the Nauraxial analgesia and will go off. No. You need a in-house anesthetist because of all these possibilities of rare but serious complications. Coming to the next type, that is the in pharmaceuticals, parenteral opioids as labor analgesia. Meperidine is most commonly used. It can be given intramuscularly or intravenously with a dose of 50 to 100 milligram intramuscularly with promethazine 25 milligram intramuscularly. Neonatal sedation is seen in 3% and it is lasting for 72 hours. It has a long duration of action. Respiratory depression can occur in the newborn, and then the naloxone is used as an antidote for that. Second dose drug is butorphanol, 1 to 2 milligram IV every 4 hours it is given. It can lead to somnolence, dizziness, dysphoria. Dysphoria is feeling of unhappiness, but it is associated with less neonatal respiratory depression as compared to meperidine. Fentanyl is a short-acting 50 to 100 microgram. It needs to be given every hour, and that is why it is less commonly used. Remifentanil can be given as patient controlled analgesia pump, PCA pump. But here there is a risk of maternal apnea, and that is why that also needs close monitoring. So, in short, these opioids need very careful monitoring, as sometimes it can lead to serious maternal morbidity or rarely maternal mortality also. Aspiration, inadequate ventilation, drug overdose, all these are documented causes of maternal deaths with the use of these opioids during labor. And neonatal respiratory depression is a real uh, possibility with a greater drug dose of the drug which is being used. Nitrous oxide has been tried along with oxygen. 50% nitrous oxide, 50% oxygen is given as a inhalation. Self-administration also can be done as per the patient's need. It is less effective as compared to other methods. It can be combined with epidural, which increases the satisfaction rate, maternal satisfaction. Side effects are nausea, vomiting, dizziness, and drowsiness, but fortunately, there are no neonatal side effects. Pudendal block and paracervical nerve block. Pudendal block, where local anesthetic drug is injected near the ischial spine to block the pudendal nerve, which takes care of the somatic component of the somatic pain, which is draining to the S2, S3, S4. We need to aspirate to prevent inadvertent intravenous administration of the anesthetics, which can lead to serious CVS and CNS side effects. 1 ml of 1% lidocaine is usually used, and then 3 ml is infiltrated in sacrospinous ligament. It helps in operative vaginal delivery, and it can be used along with epidural analgesia whenever the somatic component is not taken care of by epidural. In some cases, there is inadequate effect, and then in that case, we can combine epidural with pudendal block. But it leads, there is the pain relief is inadequate for extensive vaginal manipulations, such as uterine exploration, complete visualization of cervix and vagina. That is not possible with this pudendal block. Paracervical is usually not used as it can lead to fetal compromise by uterine artery spasm. I have never used paracervical block for a labor analgesia. There are certain recent advances. The use of virtual reality for labor analgesia is being proven in studies that it is a very effective distraction technique, reducing the need for the pharmaceutical methods of labor analgesia, and use of artificial intelligence, which is mainly to decide which method to be used, what drug, and how much dose patient might need, and need for the repeat dose also. So this is the future of labor analgesia for us. To summarize, antenatal counseling plays great role. It has to be the shared decision to decide about the need and the type of labor analgesia which will be used during labor. Every department and hospital should have standard operating procedure. We should be combining non-pharmaceutical methods to reduce the need of the drug, so that the drugs which are being used are least possible dose can be used with the less possibility of side effects. We have seen that every type of Nauraxial analgesia has also possibility of side effects. Opioids and other drugs also, whatever we are administering, these are also having possibility of side effects, maternal as well as neonatal. So we need to use non-pharmaceutical methods such as support, music therapy, hydrotherapy, doula, massage. These can definitely reduce the need for the drugs. Depending on facility, then we have to decide. In-house anesthetist is there, we can go for Nauraxial labor analgesia. No anesthetist, then we have to select opioid or NSAID with caution. So that is the reason every facility, obstetric facility, should have its own standard operating procedure. Ultimately, we have to make delivery and labor, those 4-5 hours, especially active labor, it should be made as a pleasant experience. That is the job of us obstetricians. That is the aim of this labor analgesia. These are the references. This is a very good reference, 2025, which has helped me a lot. It is a review article, and I have also gone through Williams Obstetrics and High Risk Pregnancy textbook. Thank you so much. Select a method based for your setup for RMC, respectful maternity care. Thank you once again.